So this patient we are planning for full mouth rehabilitation. This CBCT was sent by one of our course doctors. As usual, first we will see the 3D reformatted view. The important striking features are very less height, resorption, lot of resorption and thin ridges, lot of bone loss in the maxillary anterior and posterior and also in the mandible also, and the mental foramen is closer. The good thing is there is no need to do much alveoplasty. Already there is naturally a lot of bone resorption is there. Left side mental foramen is closer. So these are all the initial observation, and the main observation is this projection, this angle. So what this means is there is severe masseter muscle activity. Patient must be a heavy chewer or bruxer. So heavy force will be generated. The patient most probably will have a low face, low angle patient, which means the patient will generate heavy force. So definitely night guard should be given, soft diet should be advised. We will see the planning for the maxilla now. The second thing is we have to see the panoramic view. This is the sinus. The sinus expansion on both sides is severe. You can see the severe bone loss crustally and with sinus expansion on both sides. Even the sinus is expanded on the tuberosity also. Our tentative plan is 2 pterygoids and all on 4 in the front. First we will plan for the pterygoid on the right side. So first we will see the anatomy without the implant. You can see the tuberosity is missing actually because of long-term edentullousness. So what is remaining is only the pterygoid pillar and the little bit of tuberosity bone. Okay, so it will be a challenging pterygoid. So this is the pterygomaxillary fissure area, this narrow area. So this is PARP 3 or 4, severe sinus expansion. So it is almost like a trans sinus or distalized sinus approach. Okay, so this is the bucco-palatal cross section view, tilted medially. It is around 16 mm or 15 mm mostly. Okay. Okay. So if I plan like this, that means most of the implant is into the sinus. We can appreciate in the bucco-palatal cross section is in the sinus. But if we tilt the implant in a proper direction angle, it is into the bone, proper bone. So the key part is the direction, distal angulation of the implant, which can be confirmed by taking IOP after the pilot drill. So pilot drill is the key. After pilot drill for 5 to 6 mm, take IOPA. If the drill is in this direction, that means we are into the sinus. If this is into this direction, we are entirely into the tuberosity. So it should be in this ideal position. So this is our target area. So this is the non-fusion zone. This is the non-fusion zone. The in-between part is our target area. So this is key point, and another key point is the medial angulation. So it should be angulated medially, not like this. Okay, so we have to do it very slowly, with lot of awareness we can do it. It is challenging but not impossible, this pterygoid. The size you have to select is 3.5. Okay, if I am placing 2-piece implant, I will place either 3.5 neodent or 4 mm JD pterygoid. Okay, both are okay. If I am selecting CMU implants, that is also a good option. I will select 3.7 or 4.2 diameter implant, 15 or 16 mm length with a 30-degree multi-unit angulation, inbuilt angulation is there. So this is the plan for right pterygoid. We will see the left pterygoid now. The left pterygoid also the same, similar. Left pterygoid, there is one small challenge is there. As usual, the sinus is very much distally expanded. Tuberosity is missing by crestal bone resorption. We have to start the drilling just in front of the hameral notch, about 6 to 7 mm in front of the hameral notch. Drill 4 to 5 mm, take IUPA, make sure it is into the fusion zone, this area, and angulation, make sure it is medial. Anatomically, the challenging part is the descending palatine artery is closer to the our target area, so it may be difficult to avoid the descending palatine artery, but there is not a big complication. If you touch the descending palatine artery by drill, you will see the bleeding, pumping, pulsating bleeding from the osteotomy site. Nothing to worry, place the implant, it will stop. So the chances of the operators to see pulsating bleeding is more on the left side for this patient. Okay, so this is the pterygoid planning. Now we'll come to the distal tilt implant. So I am keeping the implant in the second premolar, almost in the second premolar. Almost I am keeping the second premolar. The sinus is closer, the nasal cavity is closer. It is around only 10 mm. So it is a very less length here available here. Now we will tilt it mesially and we will see what happens. Okay, if we tilt mesially also, the same length is there, it is only 10 mm. But if you do parallel approach and if you come parallel to the buccal aspect or towards the mesomaxillary buttress area, you will get little more longer length, around 16 mm you can get. So buttress area is a good idea for this patient. So we will see where is the target point. So just to find that, we have taken the implant out. So we need to know two details in the distal tilted implant. It makes the job very simpler. One is where you are starting and where you are ending, the starting point and the ending point. The starting point is just distal to the canine in the first premolar area. The ending point is in the buttress area, this area. This is almost in the lateral nasal wall. Okay, it is around 15 mm. Okay, either you can use a conventional implant with angulated multi-unit implant, or use a CMU and you can bend the implant. This floor here, it is very good cortical, and do minimal drilling, then you can achieve stability. The second implant is the right axial. The height is very small, but this is enough. Short implants are underused, underrated. 8 mm implant you can place, even a 3.5 mm conventional implant or a CMU implant, 8 mm implant you can place. Palatal approach, definitely. Even though the bone height is very less, the density is good, around 500 something like that. So very minimal drilling, pilot drill, 2 mm parallel drill, twist drill, and place the implant. Just we will try some tilting here to get some length. Okay, so if you tilt slightly distally, you will get 2 more implant, that's it, 10 implant. So that is one more trick we can employ, but I will prefer a straight only, or you can tilt medially also, but here tilting medially doesn't have major effect. So either we will do axially 8 implant or tilt angulate distally and place a 10 implant. Okay. So something similar, it is a kind of M approach. So distal tilted implant, the target point will be here, the axial implant target point will be here, almost closer to each other. You have to use the angulate. So this is one option. We will see the left tilted implant. Left tilted looks more challenging. You will see the first premolar axial now. This is the first premolar axial direction. Only 10 implant. Sinus is expanded very much. You will tilt. You will angulate mesially. Mesially also the sinus is coming. Okay, very short. 8 or 10 implant you can place, that's it maximum. Not a good length bone here. 8 or 10 implant, just distal to the canine. Do the palatal approach, come closer to the buccal area. Okay. Maybe like this. You can place a 11 or 12 implant. We will see the target area. So any distal tilted implant, only 2 things we need to know. What is the starting point? The starting point is just distal to the canine, and what is the ending point? It is similar to the right side, the buttress area, and what approach, palatal approach. 3 things we need to know for the distal tilted implant. Now we will come to the left axial. This is 8 implant, short implant. 3.5 is better. 8 very minimal drilling. You will get maybe 30 Newton stability, but that is more than enough. We can do immediate loading also. If you are very much worried, then you can try delay loading, but we will do immediate loading. This side you can tilt towards the midline. Actually you will get a 10 implant towards the nasal spine, 10 to 12 also. So this is one more option. So apart from this, there is one more option is also there. Instead of placing 2 implant in front, place only 1 implant in the midline. That is also one idea. Just we will try the nasoprotein canal. Yeah, so the nasoprotein canal also it is here. You can place a 4 or 3.7 implant, 12 in length. That is also possible. Midline implant. Okay, the canal looks bigger. You can put a 4 or 4.2 also. 10 or 12 So either 5 implants or 6 implants. Okay. So what is the backup option if pterygoid is not possible? If pterygoid we cannot, then the only option is to go for a zygoma. Other is one more option is also there. You can put the same all-on 4 in front, and you can go for the provisional. You can give either second premolar to second premolar. Maybe in the durable you can give molar to molar. Zygoma is also one backup option. But pterygoid, if you do carefully, slowly, follow the proper surgical technique, proper implant selection with proper ergonomics, we can place the pterygoids. It is not impossible. Now we will see the lower.